generally speaking, when we choose a test for a patient, any test, but especially for functional diseases, we should consider those 5 points for each test. First of all, of course, the diagnostic value, which means how good is the test to reveal the functional and disease condition of the patient. But the same importance is the clinical relevance. So how good is the test to help us to decide the treatment for the patient? Then, of course, availability and time are quite important, as well as avoid redundancy. So don't do many tests telling us the same information. So each test should add something to our diagnostic ability. And finally, costs. How many diseases are we looking to? We can categorize it in these 4 groups. First of all, chronic constipation, which is declining in 2 different kinds from a pure functional point of view, as a slow transit constipation and dysenergic defecation. Then the anatomical part of the constipation, known as ODS and prolapse, which could be incomplete, like just mucosal intussusception, or complete. Fecal incontinence, which is the other way around, which should always be divided in different categories as passive and urge. And finally, chronic anal pain. How many tests do we have? I said very many, but again, we still categorize all the tests in 2 big groups. The one giving us numbers, as manometry for instance, and the other one gives us images, pictures, like the echography, MRI, and whatever. Starting from chronic constipation, just an overview. The prevalence is very high, and usually we all know that it's underestimated, about 20% of the population. Is mainly an age-related condition, even if we still see every day in the daily practice quite young people, especially female after delivery, suffering from chronic constipation. The most important aspect is maybe the socioeconomical aspect, because if you see the second point, this study brings us this information about how much a patient costs per year in the USA suffering from chronic constipation, up to $7,500. And the funny thing is that most of this money is completely wasted, because more than 50% of the patients are self-medicated anyway. So we're not doing quite a lot to make those patients better, generally speaking, in terms of therapy. Which is the initial assessment for any chronic constipated patient? First of all, and we will see through these slides how much we actually can do just in the office in the very first time we visit the patient. The first bit is always the digital rectal examination, because the main task at the very first time we see the patient is to exclude any underlying disorder. So digital rectal examination is fundamental, and it can reveal strictures, mass, blood, or the presence of stools. Each time we might think that the patient might have an underlying disease, just don't be shy to send to flexible endoscopy, because we can miss a lot, especially malignancy, which could be the very first symptom of a chronic onset of a chronic constipation. But as I said, we can do many things, quite inexpensive, a little more expensive than just the simple digital rectal examination. As for instance, the balloon expulsion test. Balloon expulsion test is simply filling up a balloon inside the rectum with known amounts of air or liquid, and ask the patient to bear it down, so to bear down and extrude the balloon. From literature, it seems that when it's done in 60 seconds, or leaving a minute to the patient to extrude the balloon, in the seated position, of course, much better than left lateral position, with a fixed amount of 60 ml of liquid, can have quite a good sensitivity to reveal at least an idea of a dysenergic origin of the chronic constipation. And again, is something that we can do at the first assessment of the patient in the office. But since we are filling up a balloon inside the rectum, why don't we check also the sensitivity of this rectum, doing the well-known 3 thresholds of sensitivity: first sensation, desire, defecation, and urgency. In chronic constipation, this test is important to check what we call rectal hyposensitivity, of course. which is defined as rising one or more of these thresholds. And the reason why we check is especially because they might predict a poor outcome if we send the patient just to biofeedback. Now, those two tests are actually daily. Now, I mean, we can actually do the whole thing and much more by using this portable manometer that Alex will describe later on. So with this portable manometer, we can actually say, check all the fundamental data of any anorectal manometers: resting pressure, squeeze pressure, endurance. Of course, since we're talking about people suffering from chronic constipation, the main data we want to see and know from the clinical manometer is the activity during the strain. In other words, we want to see if there's any synergic contraction during the bear maneuver during the straining phase. And also, having a sensation probe, we can check the sensation at the end of the manometry. So, if we see and find any pathological finding, we are completely allowed and entitled to start our conservative measures, which means toilet training up to stool consistency management, as well as sending the patient to a biofeedback or rehabilitation of the pelvic floor. This is true even if we know that most of the time it doesn't exist a pure dysynergic obstructive defecation, as well it doesn't exist a pure slow transit constipation. Most of the time they overlap each other. Even if it is absolutely true, it seems that the most reasonable way to manage those patients is first try to make better the synergic function, because in patients with both conditions, transit itself can improve, maybe not in a long-term follow-up, but initially, even if we just improve this synergic condition. So, before going to deeper investigation of the transit time of the colon, we should consider the biofeedback and the conservative measure. Let's say that we're not happy, so we go to the next step. How we do assess low transit constipation? There are three ways, and actually are depicted all here. So the radiopath markers, the scintigraphy, and much more than wireless motility capture. Definitely the radiopath markers are the cheapest one, easiest one to achieve, to find what radiologists doing this test, and usually this test is more than enough to tell us if the patient actually has a severe or an important slow transit constipation. The limit of this test is that you're not assessing at all the gastric emptying and the small bowel, and they could be useful, those information, especially if we want to use the last categories of new drugs, especially prucalopride and lubiprostol. Then moving to the anatomical part, because again, we know that the functional part most of the time is just the beginning of a chronic constipation that leads to a severe changing of the anatomy of the lower pelvis and the rectum itself. So the way we assess the anatomical part of ODS is usually by imaging. Defecography, no matter if it's done by X-ray or MRI, US scan, done in many ways, and I'm sure that Mr. Santoro will fulfill or any question about it, and high-resolution anorectal manometry. Which information comes from any kind of defecography? Paradoxical puborectalis contraction, rectocele, rectoanaline, tussusception, complete rectal prolapse, and descending perineum syndrome. So each time we look at the image of the pelvic floor done by an MRI or a defecography, we just bear in mind that those are the things that we're looking at. Which is better? There's no answer. Definitely, historically, X-ray defecography is the most commonly used test for this purpose. So the experience in defecography is definitely much higher than MRI, but MRI is a much better instrument, and we will see some image. Now, anytime we do use both of those tests from a technical point of view, the information we are really interested in is the anorectal angle, like Alex said, presence of any anatomical changing, like you see on the left, is big rectocele, anterior rectocele, and of course, how the pelvic floor is descending, starting from a line, going from the coccyx to the pubic bone. Same concept is applied to MRI. It doesn't change the concept, it just changes the machine that shows us any significant changing. I brought this picture because, of course, if we, again, want to compare those two techniques, we end up with no superiority between one to the other one. Of course, X-ray is much cheaper and available, even if MRI is pushing quite hard forwards to replace it, maybe. The reproducibility of MRI is definitely higher, but what is the key point still is that lithography is much more physiological because it's done in a seated position, as well we were saying about the balloon expulsion test. If you ask somebody to bear down and extrude the stools, if they're lying down on the left side, it's not going to be very physiological anyway. The other important, very important information in this slide, I think, and maybe is the most important, is the last. Never rely only to these tests to decide a treatment for the patient, because it's well known, as well as well known in manometry, that many, many pathological findings are seen in asymptomatic people. So you don't decide to operate a rectocele because the MRI is showing that. You decide to operate rectocele based on the symptoms. So those are just tests that helps us to confirm our diagnosis. They are not, no one is the test that's telling us what to do. From a personal point of view, though, if we would compare the X-ray MRI to the X-ray lithography to the MRI lithography, for sure, the relationship between the compartments, so how the pelvic organ actually moves inside the abdomen, is better shown in MRI. So you see, for instance, if the video works. Does it? Yeah, it does. Quite a significant enterocele, just lowering the double patch. Now, most of the time, even if it's possible in the lithography, X-ray lithography, this image is helping us a lot to decide which way to approach the problem. And this problem I would approach from an abdominal point of view rather than a perineal point of view, because this big enterocele definitely needs the Douglas to be lifted somehow. Same for this example, where you see a very significant anterior prolapse during the bear down maneuver. That means that the pelvic floor actually needs a huge help to be restored. What about ultrasound for chronic constipation and diagnose anatomical condition of the lower rectum? It's definitely a promising technique. It's much easier, it's very available. The problem is that there's kind of a new technique, and one of the main limitations is that it's done in several modalities, like perineal, endoanal, and vaginal, with many, many different instruments. So let's say that today we cannot standardize the ultrasound approach for chronic constipation, but still a very interesting diagnostic tool that I'm sure that in a few years will not replace, but be very helpful in an immediate and inexpensive diagnosis of most of the anatomical condition of the lower rectum. Is there still a role for high resolution anorectal manometry? Again, I'm just touching this argument very quickly because Alex will show the latest bedside anorectal manometry. High resolution anorectal manometry compared to the new instrument is actually giving us just one information more, which is this famous defecation index. So is the ratio between the intrarectal and the sphincter pressure. Is that useful? From literature, we know that doing so, so having the difference between the endorectal pressure and the anal canal pressure, we can put our patient in those famous Rouse categories, Rouse groups. But again, as I said about the anatomical assessment of the prolapse, very often alteration of this ratio between the endorectal and the endoanal pressure is seen in completely asymptomatic patient or even in controlled patient in the studies. So the clinical meaning of this information today is quite poor. So if we want to draw a diagnostic algorithm in chronic constipation, and it said all what you said, we said to sit down, starting from a patient suffering from chronic constipation, the very first thing we should do is a digital rectal examination and all the balloon expulsion test, checking the volumes, or even better, a clinical manometer. Now, in case of possible dysynergic problem, quite obvious dysynergic, then send the patient to conservative measure and biofeedback. In case of possible slow transit, so no much finding with the very initial test, or in failure for biofeedback, then try to start checking the colonic transit time. If colonic transit time comes pathologic, then it's up to us. Surgery, not very useful. Drugs, let's try, because in a short term, the new drugs tend to work quite well. If we think that it is more an anatomical problem rather than a functional, then we can think about imaging of the pelvic floor and the lower rectum by echography, X-ray, MRI, and so on. But I put a question mark. Do that just if you plan to operate on them, because just doing a test with no clinical meaning, which means that it's not leading us to decide any surgical treatment, it's just a waste of researchers' time and it's completely useless. Now, what about fecal incontinence? Still, another rising problem. We will have a talk, especially for fecal incontinence, so I will touch it quite quickly. Anyway, up to 7% of general population suffering from fecal incontinence definitely is an age-related condition. So after 75 years old, the incidence is increasing much. Again, if we look at the cost, each patient treated for fecal incontinence seems to cost $17,000. Very important is to assess the category where the patient falls, from the passive incontinence to the urge incontinence, fecal seepage, and the overlap of all three. It is important because the treatment changed quite radically. Now, the very first assessment for fecal incontinent patient is the inexpensive one, so just ask and listen. This is a set of questions that we should always do to people suffering from this condition. And just by the history, we allocate the patient in one of these three categories. So passive, which means involuntary discharge without awareness; urge, that means discharge in spite of active attempts to retain; and seepage, which is very common, is the undesired leakage of stools that happens very often after defecation. Now, then we choose the test, and there are some which are mandatory to decide what kind of treatment or what kind of management of this patient we will prefer. But still, keep in mind that, especially if you want to treat a patient suffering from fecal incontinence, is very important that we exclude any organic origin of the fecal incontinence, because we can miss a neoplasm that is, for instance, the main reason of the incontinence of the patient, concerning mucus in the lower rectum that the patient cannot hold, but he doesn't know, so he's complaining for the soil. Then, after excluding any possible origin, inflammatory or organic, of the incontinence, those three tests are really fundamental for any patient suffering for FI. Anorectal manometry, which is giving us the numbers on the function of the sphincter muscle. anorectal endosonography, which reveals whether the muscle is broken or not, and the rectal value and the rectal sensitivity. Then we will talk a little about the pudendal nerve terminal motor latency. Now, again, talking about clinical manometry, Alex will fulfill most of your question about it, but this manometry in fecal incontinence is important because it's giving us these four information. So the resting pressure, expression of the activity of the internal anal sphincter, the squeeze and endurance, which is the expression of the external anal sphincter activity, and the rectoanal reflexes. Those are just examples showing how easy it is to just interpret the manometry result looking at the wave. So if the top picture is a normal manometry wave, where the part between the red lines is the expression of the external anal sphincter activity by voluntary contraction, is very, very immediate and easy to understand that in an incontinence patient, this part is completely lacking. By 2 minutes test, we already know that this patient has a severe lesion in the external anal sphincter. And again, we will go through it much deeper later. Same for this example, normal wave, and a very sudden drop of the external anal sphincter activity in the red, between the red lines, means that the contraction of the external anal sphincter doesn't last in time. High resolution anorectal manometry. In my opinion, the rule for this very complex, long, and difficult to read test is reducing daily in patient with fecal incontinence, because the quicker techniques, the quickest instrument we're using now are good enough to tell us the information we were talking about just a second before. Now, endoanal ultrasound. The endoanal ultrasound is the fundamental test to know if those muscles are broken or not. In other words, if the patient suffering from fecal incontinence does suffer because the sphincter are broken, or the sphincter are completely anatomical, well performed, but are just weak. And there are many, many ways to perform endoanal ultrasound, and I think that we will discuss much more later. Anyway, this is something that is very interesting, because this is a test which is really poorly performed in the daily activity. The pudendal nerve terminal latency actually measures the neuromuscular integrity between the terminal portion of the pudendal nerve and the anal sphincter. An injury to the pudendal nerve, which is extremely common in deliveries, especially in prolonged deliveries, actually cause a denervation, even partial, and so a weakness of the sphincters. So why are we actually checking this function, this condition? Because if we decide to surgically repair, or do anything else surgically to improve the continence of the patient by acting and working on the sphincter, we should know if the sphincter is well innervated or not. It's like trying to change the valve if the circuit is broken. So I think that this test should be much more in our common evaluation of the patient rather than it is today. If you wanted to draw a fecal incontinence diagnostic algorithm, then starting by history and digital rectal examination, then we have two possibilities. Do we think that the patient suffering from urge incontinence then go to endoscopy, because urge incontinence is much more likely to be associated with something in the rectum, rather than whether it's inflammation, infection, or a tumor. And whatever we found from the anatomical point of view, then we treat this first. If it's negative, or we think the patient is suffering from passive kind of incontinence, then clinical manometry, anal ultrasound, and balloon expulsion test. We can go deeper with high-resolution anorectal manometry or pelvic floor MRI, but it's very uncommon that we need more information. Then, two possibilities again. Are we going to surgery, PN, TLM, or EMG? Are we going to conservative measures, biofeedback, implant, then we quit the diagnostic activity? Finally, I want to touch the chronic anal pain just because the incidence is much more higher than we think. About 5–6% of the general population. The problem is just 1 in 3 patients actually refer for any treatment or any diagnosis. There's a large differential diagnosis, but bear in mind that most of the time, 85% of the time, you won't find any anatomical problem, any anatomical finding. Is most of the time a pure functional problem, like this study reported. The first kind of chronic anal pain in terms of incidence is what is known chronic proctalgia. What is known as chronic proctalgia is just an euphemism because this condition has very many names like Lever-Ani syndrome, pubertalic syndrome, idiopathic anal pain, piriformis syndrome. The characteristic of the pain is mainly clinical, and is the diagnosis of the different kind of pain is mainly clinical. So the chronic proctalgia is characterized by a pain that lasts more than 20 minutes, is usually during the day, in the seated position more often, and during defecation. So if we want to reveal this condition, most of the time the diagnostic test we use is, of course, digital rectal examination, manometry, and defecography, looking for some contraction, hypercontraction, dyssynergic contraction. What about coccyglodyne? This is a pain around the coccyx, so it's higher than the anus, but it's, most of the time it's difficult for the patient to reveal the real size, so that's our job to do it. Pain arising around the coccyx, usually in the seated position, and the diagnosis is made if the pain actually lasts more than 3 months. Very common to find previous major or minor trauma in the history of the patient, and is more common in female with high BMI. Diagnosis test, coccygeal manipulation is usually very, very useful because we can do the bimanual manipulation of the coccyx, eliciting the pain. So we, by just doing a clinical examination, we usually are able to do the diagnosis. Of course, X-ray to see any previous trauma or bone lesion or MRI. Hancock syndrome is characterized by a superficial pain, which is different in the kind of pain because it's most of the time a burning, a superficial pain. Often comes with paresthesia in the genital and lower leg area, and at the very beginning in the history of the patient is usually monolateral. So if we ask the patient, try to remember how was actually rising up at the very beginning, they tend to tell you that it was mainly in one side, and then by the connection of the superficial nervous system, it gets bilateral. Diagnostic test, usually EMG or the pudendal block, which is the diagnosis for the Alcock syndrome. We just put some anesthetic through the Alcock canal, and you see if the patient is relieving from the pain. So in conclusion, incidence of functional anorectal disease is high and is rising. Each patient usually needs a series of exams, but the best way to better assess and save money and time is a step-by-step approach to the problem. Functional pelvic diagnostic assessment is in complete evolution, especially from the US point of view, and the diagnosis of chronic pain is mainly clinical. Thanks a lot.